So let me just give you one example here. So I trained as an interventional cardiologist. So essentially, having done cardiology, I subspecialized where I was doing, in layman's terms, keyhole heart surgery on patients. And I've done thousands of angiograms where you diagnose people with coronary artery disease from this procedure. But also we do something called stents. Now, many of you may know of stents. Essentially, it's a procedure where we unblock people's arteries by passing a tube into the arteries and inflating a balloon and deploying a small metal scaffold. But the reality is that although it's life-saving for people having a heart attack, and I'll tell you exactly how life-saving that is later, for people who are not having a heart attack, people who have stable heart disease, it does not prevent heart attacks or prolong life. And we have very good extensive evidence for many, many years that it doesn't do that. But it's estimated in America almost half of all the procedures for stents on many, many patients costing millions and millions of dollars actually is carried out is of questionable value, despite this body of evidence. But most importantly, 88% of patients undergoing the procedure thought they were having the procedure for the very purpose for which it doesn't benefit them. And when anonymously asked, 43% of cardiologists said they would still go ahead and do the procedure even if they felt it would not benefit the patient. Now, this is not a procedure that doesn't come with harms. So at the end of mid-2013, and then following on several months later, I wrote 2 consecutive editorials by coincidence. The first one was in the BMJ, called Too Much Angioplasty, and the second one was in JAMA Internal Medicine. And the first article I wrote was actually pegged on the fact that I was emphasizing this level of misinformation actually no one is immune to. In fact, it probably, in this case, went all the way up to the former president of the United States, George Bush. So it was widely reported in America that George Bush received a stent for heart disease. However, apparently he had been cycling 100 miles a week before. There was no report that he'd had a heart attack. And as far as we know, he just went for a routine check under his cardiologist and ended up with a heart stent. And my guess is this, that ex-President Bush probably wasn't told it wasn't going to prevent him having a heart attack or prolong his life. So I basically wrote an editorial saying that actually we need to be more explicit with patients and emphasize the importance of lifestyle changes and medications that can help prevent heart attacks. But certainly this procedure, there isn't fully informed consent because the actual procedure itself does carry a risk, a 1% risk of having a heart attack, stroke, or death. And in my career, I've seen patients, unfortunately, have suffered a complication that couldn't be predicted, where they've either had a stroke on the table or they've died. And I thought to myself, wow, this patient's symptoms weren't that severe, yet if they'd probably been left alone and hadn't had the procedure, they would still be alive today. Or they may have changed the decision-making process about, if they were informed about the actual true benefits of the procedure, they may have changed their mind and not had it done and still be alive. So, I emphasize that we should actually make this mandatory in the consent form to protect patients from these unnecessary harms. And the second editorial on JAMA Internal Medicine was really re-emphasizing that. It was press released and picked up by BBC News. And interestingly, the chairman of the Academy of Medical Royal Colleges, the body in the UK that represents almost every doctor, agreed with me, said this was a legitimate concern in the press release. The British Cardiovascular Intervention Society, interestingly, run by cardiologists who do heart stents, their response was they didn't think that changing the consent form was actually the best way to manage this problem, which I thought was very interesting. But clearly there is a bias there. What I didn't predict is several months later, JAMA Internal Medicine then published a paper where they actually gave this scenario to patients, see whether it would change the decision-making process. And it actually did significantly. When patients were told there wasn't a benefit from stenting for stable disease in preventing a heart attack, stroke, or death, they changed their decision-making process, reducing the amount of people having a stent by about 25%. And it was estimated if this conversation was to go on, just a very simple, transparent conversation across the United States with cardiologists and their patients, then reducing the amount of unnecessary treatments would potentially save US healthcare $864 million a year, just from one conversation about one particular procedure. Okay, so misunderstanding of health statistics is also a major risk factor for misinformation. So many doctors, surprisingly, don't understand health statistics and therefore cannot evaluate evidence for and against a treatment. So in one study several years ago of 150 gynecologists, a third did not actually understand the meaning of a 25% risk reduction from mammography screening, so screening for breast cancer. Most of that third believed that if all women were screened, 250 out of 1,000 less would die of breast cancer. But actually, when you look at the data, you'd have to screen 2,000 women to prevent one death from detecting and saving them from breast cancer. So 1 out of 2,000 is actually the actual figure. And a smaller study that was carried out a few years later, despite this awareness, although many of the doctors asked knew about the benefit not being that great, none of them were aware of the harm. So for every one lady that was saved from breast cancer from screening, 10 were harmed by receiving an unnecessary treatment or an operation. So let me just give you a very basic, simple mathematical education on statistics here. And it's not rocket science, and I think this is a crucial part. So there are many ways of actually presenting a benefit: a relative risk or absolute risk, also known as the numbers needed to treat NNT. So if you communicate relative risks, as opposed to NNT or absolute risk, it can actually lead lay people to, and doctors also, to overestimate the benefits of a treatment. So let me give you an example. For people with type 2 diabetes, the published medical literature tells us that if you take atorvastatin, a cholesterol-lowering drug, 10 milligrams every day for 4 years, there's a 48% relative risk reduction in having a stroke. That sounds quite impressive. You're 48% less likely to have a stroke if you take 10 milligrams of atorvastatin every day for 4 years. But what does that actually mean when you look at the data? Well, it means you reduce the risk of having a stroke from having no treatment, no statin, from 28 in 1,000 to 15 in 1,000, which means there's an absolute risk reduction of 1.3%. So what does that mean for the individual in real terms? The actual way to say to that patient is, if you take atorvastatin 10 milligrams every day for 4 years, there's a 1 in 77 chance that the drug will prevent you having a stroke. Very different to 48% relative risk reduction. Most people do not benefit. The benefits are small, but you may decide that that benefit is good for you, or you may decide it's not. It's very different. Now, mismatched framing in medical journals that we rely on to give us information about benefits and harms of medications has made the situation worse. So if treatment A reduces a risk of developing a disease from 10 to 7 in 1,000, but increases the risk of the harms from 7 to 10 in 1,000, the journal article would present the benefits as a 30% relative risk benefit or reduction, but the harms as 0.3% when they're exactly the same thing. How common is this? Well, one analysis looking at articles, a third of articles, in fact, published in the BMJ, JAMA, and the Lancet between 2004 and 2006 used mismatched framing when presenting information on the benefits of a drug and the harms. It's extraordinary. This is not science. This is marketing. And this asymmetric presentation of, obviously, benefits and harms was going to lead to overtreatment. It's going to exaggerate the benefits of a medication and reduce the risks, or the perceived risks. And by the way, this is all still best case scenario. I'm going to go further deeper into this as well shortly. So don't just take my word for it. The man considered probably the world-leading researcher in health literacy in Berlin, Gerd Gigerenzer, he said in a World Health Organization bulletin in 2009, it is an ethical imperative that every doctor and patient understand the difference between absolute and relative risks to protect patients against unnecessary anxiety and manipulation. In other words, and this is what I believe to be true, unless you have this conversation with a patient, unless your doctor tells you the absolute benefit of a drug you're going to take, then it's not being ethical. I think this is unethical practice. That's essentially what Gerd Gigerenzer is saying. But we are unwittingly practicing unethical medicine. Most doctors want to do the right thing, but they're misinformed. Let me give you a case study. People like case studies. They're interesting stories that kind of tell you a lot of different interesting things about what we're speaking about today. So I saw a patient, 48-year-old man, had type 2 diabetes. He'd been seen in outpatient several months after having a heart attack. He'd received a stent. He'd survived, and he was put on a cocktail of medications. And he comes back to see me in clinic, and he's reporting very disabling chest pain. Now, as a cardiologist, if you've had a patient who's had a heart attack and had a stent, and there's often sometimes some other underlying disease there, you worry either has a stent blocked off as a new disease, but the history, most importantly, didn't suggest anything serious. But just to be on the safe side, we decided to book him for a repeat angiogram to look at his arteries and check things are okay. There was clearly not having a heart attack, but there may have been a new blockage that was causing him problems. So we booked him for an angiogram. I did the angiogram. I looked at his arteries. Everything was fine. It was very reassuring. And I said to him at the end of the procedure, listen, everything's okay. There's nothing wrong with the heart. This could be coming from your stomach. Because he said, well, doc, that's great, but why have I still got this pain? What am I going to do? I said, this could be coming from your stomach. Sometimes chest pain can be coming from the acid reflux. So we put him on some medications and said, go back to your GP or general practitioner, and we'll follow you up and see how you get on. So he was reassured, put on this proton pump inhibitor drug. He comes back 6 weeks later, arranged to see him, and he said, listen, this pain is still there, it's getting worse. I've also got these other things I didn't mention before. I've also got these muscle aches and I'm feeling fatigued. He was with his wife, who was also very worried because he's now depressed, and she says he's been depressed now for months because of these pains, disabling pains that he's got. I spoke to one of my colleagues and he said, oh, look at his medications, maybe it's something in the medications. Maybe it's a statin. I thought, well, that's interesting. Statin causing these side effects? Okay. So I said to him, listen, we're going to stop your statin for a couple of weeks, go back to your GP and see what happens. Now, what's happened in the meantime is GP has already referred him to a gastroenterologist. So he's now about to go and get because the drug that he took for his so-called chest pain that was thought to be maybe coming from the stomach wasn't helping him. So he's now about to go and have an endoscopy. So an invasive investigation where he's going to have a telescope camera passed into his stomach to look for an ulcer. So this is being organized. I can't see him just because obviously, with the way things work, it's a non-urgent case. So, I arranged to see him a few months later, but he turns up uninvited. A week later, he turns up to the clinic knowing that I'm in clinic, and he knocks on the door and he comes in and he says, thank you, doctor. After months of misery, I've stopped his statin. My pain has disappeared, but now I'm worried. My GP has said you must never stop your statin or you will die. Okay, now I want to ask the audience here, does anyone have any idea roughly what his risk of death is? So he's taken a statin, he's had a heart attack, there's evidence based that statins are beneficial in people with heart disease. But what do you think his risk of death is from stopping a statin for 2 weeks? That may have been causing side effects, he's had a heart attack. Any guess here? In terms of percentage figures here, what do you think? 1 in 100, 1 in 50, 1 in 10? Any guesses from the audience? Anyone that hasn't heard me say this before? Go ahead. 0. Okay, 0. Well, maybe you know something I don't. Probably very close to 0. Probably worst case scenario, based upon the published evidence, 1 in 10,000. So this chap's risk of death for stopping a statin for 2 weeks is 1 in 10,000. Yet the GP has said, you must never stop your statin or you could die. Okay, so clearly there's an issue there. Now, in the end of 2013, there was a controversy that started because there was calls that were coming from various quarters of academia suggesting we should expand the use of statin drugs to more people taking it, essentially healthy people, which in effect would reduce the threshold. Ovid and colleagues did an analysis of data that was already published, by the way, most of it all industry sponsored, to actually see whether there was any benefit in terms of reducing death rates in people at low risk of heart disease. And in the editorial, they said that there was no mortality benefit. In other words, you will not live 1 day longer from taking a statin. But also, he suggested actually we should be concentrating more on lifestyle changes. 80% of heart disease is related to lifestyle, diet, exercise, that kind of thing, smoking reduction. And by coincidence, in the same paper, in the same journal of the BMJ, I also wrote an editorial, which was called "Saturated Fat is Not the Major Issue," and that editorial was press released by the BMJ and became a big news story. It was front page of 3 newspapers. It went all around the world, essentially because a cardiologist is coming out and saying, God forbid, saturated fat that we think clogs the arteries actually doesn't clog the arteries at all. The data doesn't support that, and if we should be turning our attention to sugar. But in the same editorial, I also mentioned the fact that we've overprescribed statins to millions of people because there was no benefit for low risk. And the side effects, based upon some observational studies and my own experience, is probably affecting 1 in 5 people. Now, the side effects are unacceptable, essentially, to patients. But there was a backlash a few months later. So this got a lot of attention. The saturated fat was the main story. But a few months later, Professor Sir Rory Collins of Oxford University, considered probably the leading statin researcher in the world, who's done lots of drug trials on statins. He came out and in the front page of the Guardian newspaper in March 2014, several months after the papers were published, he basically called for retraction of both John Abramson's paper. John Abramson said the same thing about side effects that I did, and said that this could cause, unnecessary deaths of people stopping their statins from fear-mongering. It's interesting, he said that, the serious side effects are very rare, and essentially that, these symptoms are very, very rare. From our data, we don't have any evidence of any significant side effects. So ultimately what ended up happening was this then it went for a review. There was a lot of pressure on the editor of the BMJ, Fiona Godley, and I think rightly so, that she decided to send these both articles for review to see whether they should be retracted by an independent panel. While this was going on, in the interim, NICE, National Institute of Clinical Excellence, our health watchdog, interestingly, came out and decided that we should be giving statins to more people, and we should prescribe them to low risk, which will ultimately result in GPs being financially incentivized to prescribe statins to people at low risk of heart disease, despite the fact there was no mortality benefit. The non-mortality benefits at best were about 1 in 140 of preventing a non-fatal heart attack or stroke. So they came out, but there was a response. Actually, a number of doctors, eminent doctors, including Sir Richard, who is here, Richard Thompson here today, the former chair of the Royal College of General Practitioners, a number of other doctors wrote a letter to the Secretary of State for Health and the chair of NICE to say, actually, we think this is not a very good idea. We think it will ultimately cause more harm than good. And we gave a number of reasons in a very extensive document. I was also a co-signatory, saying that basically all of the guidance on statins was based upon industry-sponsored studies, which is a crucial element of all of this. The side effects weren't taken into account, including type 2 diabetes. We know statins do cause type 2 diabetes in probably about 1% of people. And most importantly, there's a mortality benefit. These patients are not going to live one day longer. So mass prescription of statins ultimately we thought would actually put more pressure on the system and wasn't a good idea. So this actually got a lot of attention. It became a big news story. And this was while this whole review panel thing was going on. And the review panel came back 6-0 in our favor, saying there was no reason for retraction. There maybe was a minor correction that needs to be made about the quality of study that was used to make this claim about 20% side effects. And that should have been the end of it. Also, the General Practitioners Committee backed us as well, because they said that because we don't have access to all the raw data on statins, and also based upon the fact that the UK stockpiled Tamiflu, which we spent £500 million on a drug that ultimately, when independent researchers were able to access the data, revealed was no better than paracetamol for helping people for influenza, until we get the access to the raw data, we actually, as general practitioners, the ultimate committee that would help decide, make these recommendations, they revolted, this is unprecedented, against the health watchdog. The other issue as well that I didn't mention is that NICE, the panel who were involved in making a decision on recommendations, several members of the panel had direct financial ties to the drug companies manufacturing statins. So again, we felt this was a bias. Now, the saga continued. It didn't stop there. And I'm going to jump forward because I know we don't have a lot of time, but essentially what ended up happening then is Professor Collins then referred, he was not happy, there was no retraction, and Professor Collins, who felt very strongly that there was a over-exaggeration of the benefits of the harms of statins from side effects, he referred the editor of the BMJ to the Committee of Publication Ethics for editorial misconduct, which some people felt, if she was found guilty, would have resulted in her sacking. And it may well have done. Luckily, that didn't happen. But after this, The Lancet then published a paper basically suggesting that we've now done a reanalysis with the same researchers who suggested statins are great, including Professor Saru Collins, who's one of the lead authors, to say that actually, no, statins are great. There's no issue of side effects, really. It's very little. And overall, the benefits outweigh the harms, even in low risk. The Sunday Times does an investigation about a month after that was published in The Lancet, so John and God Thomas. And what he found was really interesting, and I think, it's certainly puzzling to me. So he mentions Professor Collins's work where they'd then come to the conclusion maybe 1 in 50, 1 in 100 people may suffer muscle symptoms from statins, although it's reversible, and that's true. Professor Collins, who also believes more people should be taking statins, is a co-inventor of a test that identifies susceptibility to muscle pain from statins. Well, that's interesting. The test, which was branded as Statin Smart, was sold directly to the consumer for $99 on a website that claims 29% of statin users will suffer muscle pain, weakness, or cramps. And the marketing material also claims that 58% of patients on statins stop taking them within a year, mostly because of muscle pain. And that's true. When you ask patients why they stop their statins, most of them stop them within a year. They say because they get muscle pain and symptoms. Royalties from licensing of the patent can be used to fund university research, but Professor Collins waived his personal fees. And Boston Heart Diagnostics, interestingly, that they stood by their claim. They had the license on the actual test. And they said that randomized controlled trials, such as those used in the Lancet study authored by Collins, had major limitations because patients with statin intolerance were often excluded. So that's part of the problem, is the actual trials don't reflect a lot of patients who must suffer muscle symptoms, partly because in run-in periods, before the trial starts, people who are non-adherent to statins are taken out, probably because of side effects in my view, and also the people in the drug trials themselves often don't represent the people we see in the real world who are on statins, who have lots of different illnesses and maybe older, for example. John Unger Thomas then did a Freedom of Information request to find out whether Oxford University and Professor Rory Collins' department had received any money from the sale of this test that tells you whether you're likely to get muscle symptoms from statins by testing for a gene. And what he found was, yes, they had received, University of Oxford had received over £300,000 for the sale of this, and Professor Collins' department had received over £150,000. And this thing that he invented, he was a co-inventor on, actually came to fruition in 2009. 2009. So I'm puzzled by this. If the side effects are so rare, my question is, why would you invent something to test for side effects and make money out of it, or your department make money out of it? I'll let you draw your own conclusions. So let's just take a step back for a second. You know, there is a system failure here. There's a bigger picture, and I think we need to acknowledge something else. Peter Wilmshurst, who's a cardiologist, a very respected cardiologist in the UK, in the Centre of Evidence-Based Medicine in 2014, giving a talk, he points out a few, I think, really important points. First of all, pharmaceutical companies and medical device companies have a legal obligation to make profit and declare a shareholder dividend by selling their product. They are not required, although we would believe it to be the case or hope it to be the case, they are not required to sell consumers, patients and doctors the best treatment. But what he says is the real scandals are this: regulators fail to prevent misconduct by industry, and doctors, institutions and journals that have responsibilities to patients and scientific integrity collude with industry for financial gain. Peter Wilmshurst has just submitted evidence I'm going to talk about briefly now to the Science and Technology Committee in the UK, who are investigating research misconduct and scientific integrity. And here are a few key points that gives you a bigger picture issue of why this is a system failure. First of all, academic institutions bear responsibility to publish. So there's pressure to publish for career advancement. And that can result in research misconduct. A record of prominent publication can actually attract future funding, often from drug companies, and good publicity, which institutions obviously like. Other pressures for misconduct come from association with industry. He says some publications are simply organized criminal activities, which may be at the behest of the sponsors, when prominent academics are paid large sums of money to publish false data by industry, or a sponsor may be one of the victims when payments for conducting research are made to the investigators who simply fabricate data. Medical journals have a financial pressure to publish positive findings of research on drugs and medical devices because their manufacturers buy reprints for the papers and distribution of doctors. They then pay for advertisements as well, linked to articles that are favorable to their product. So to protect their reputations, academic institutions conceal research misconduct, destroy evidence, and silence whistleblowers. By the way, if you look at the document which is available online, you can find examples of all of this. I'm not going to go through it because I think that would be unfair, but you can find this. Journals are reluctant to admit that they have published flawed research, so they commonly refuse to publish failures to replicate. Fear of libel action contributes to the failure to expose research misconduct. Because lenient sanctions are imposed, institutions believe that the misconduct is not very serious, and therefore fraudsters are not deterred. And he says the best way forward really is for criminal action for certain forms of research misconduct, and I agree with him. Now, one example here, one Dutch researcher in 2011 was found guilty for publishing fictitious data on the use of beta blocker drugs for non-cardiac surgery. And he was expelled from his institution. But what was very extraordinary is that his research, many papers were published in very high-impact journals. He influenced the European Society of Cardiology guidelines. And this research, it's estimated that it resulted, the use of beta blockers where it wasn't indicated ultimately, when it was found that this data was dodgy. It's estimated that over Europe, over 8 years, across Europe, this was responsible for 800,000 excess deaths. 800,000 excess deaths. Peter Gosha, co-founder of the Cochrane Collaboration, who's done a lot of work in this area around research misconduct, scientific integrity. He wrote a piece in the BMJ not so long ago. He's written a book about this. Is actually one of the other issues is the fact that there is a lot of problems of major pharmaceutical companies being found guilty for fraud, essentially. In the United States in particular, between 2009 and 2014, there was a total of around $14 billion worth of fines paid for illegal marketing of drugs, hiding data on harms, which involved the majority of the top 10 pharmaceutical companies. But the problem is that there is no incentive for them to stop doing this. There doesn't seem to be anything changing the system. And what he says is that if you commit crime and crime pays, you commit more crime. And that's what they are doing. Let's talk about the innovation crisis. We keep hearing about, oh, we need more innovation, more innovation. Well, what innovation have we had in the last couple of decades? Between 2000 and 2008, of the 667 new drugs approved by the FDA, only 11% of them were found to be truly innovative. Most of the other drugs that have been produced have essentially been copies of old ones at great cost and no extra benefit. And perhaps not surprising when drug companies spend at least twice as much on marketing than they do in research and development. So we're not investing enough in research. We're not going to get new blockbusters, are we? The former editor of the New England Journal of Medicine says it's no longer possible to trust, this is the highest impact medical journal in the world, by the way, says it is no longer possible to trust much of the clinical research that is published or rely on the judgment of trusted physicians or authorities of medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. That's quite extraordinary. Is she alone as a journal editor? No, she's not. Richard Horton wrote an editorial in 2016, and he said possibly half, according to people that he'd met, senior academics who he said will remain anonymous, possibly half of the published literature may simply be untrue. Because of several recent scandals in British universities, Richard Smith, former editor of the BMJ, also wrote, "Something is rotten in the state of British medicine and has been for a long time." And he refers to speaking at an event with lots of academics where he asked the audience,